Our abdomen is the core of our body, and when it hurts, we'll do anything to make it better. This time, On Call examines disorders of the abdomen. The doctors are on call tonight.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing.
Just your head.
Pull red handle to open bag.
Good evening. To help people with abdominal pain, one might need to consult experts from several different fields of medicine, to include general surgery, radiology, gastroenterology, as well as endocrinology, obstetrics and gynecology, psychiatry, maybe even oncology, to name a few. During the medical students' training, most of us study the short and classic medical textbooks by Sir Zachary Cope entitled Cope's Early Diagnosis of the Acute Abdomen, where we learn about the causes of an acute or recent and severe abdominal pain, and to understand when the patient should go to surgery. The causes for acute abdominal pain, which will likely require emergency surgical intervention, include problems like appendicitis, gallbladder disease, a ruptured spleen, blocked or bleeding or perforated stomach or intestine, and the list goes on. And then there is the story of chronic abdominal pain, which can be so very challenging since the exact cause is often elusive. It requires understanding not only available technology to evaluate such problems, but also sometimes knowing when to stop hunting for the cause and instead to start learning how to live with it. Problems causing chronic abdominal pain include celiac disease, ulcerative colitis, Crohn's disease, dysfunctional gallbladder, pancreatitis, irritable bowel syndrome, ischemic bowel disease, adhesions, and so on. Well, we invite you at home to call with your questions concerning abdominal pain or disorders. Our phone number is 1-888-376-6225. Again, that's 1-888-376-6225. Indeed, the topic of abdominal pain is challenging, and to help us answer your questions about this difficult and very broad issue are Dr. Cristina Jensen of the Avera Medical Group Gastroenterology in Sioux Falls, and Dr. Michael Bauer of the Surgical Institute of South Dakota, also from Sioux Falls. Thank you both for joining us. So, Cristina Hill, you're a gastroenterology internist. Mm-hmm. Tell me a little bit, by the way, where are you from originally?
I'm from Brookings.
Oh, I thought I knew you.
Yes, yes.
So, what is a gastroenterology internist, and what was your training all about?
Sure. No, after medical school, I spent 3 years in an internal medicine residency, so adult medicine. Became board certified in that, and then did a 3-year fellowship in gastroenterology. So focusing specifically on the digestive tract and liver, pancreas, spleen.
All those things in the gut.
Yes, exactly.
And then you came back to South Dakota how long ago?
I did. It'll be 5 years this July.
5 years?
Yeah, it goes by really quickly.
Yeah. Mm-hmm. When you're busy.
Exactly.
Yeah. And Michael, you were on the show a year and a half ago or so. You're a general surgeon. Tell me about your training.
Well, after medical school, which is 4 years, the typical general surgery residency is about 5 years in training. And I did my medical school in the University of Nebraska, did my residency in Columbus, Ohio, and come back to be this area.
You're from Nebraska originally?
Yeah.
So,
yep.
And you've been here for?
Just over 2 years.
So we're out here practicing in South Dakota for 2 years.
Yeah.
So let me start with how much of your surgical experience is in the abdomen?
The majority of mine is pretty much all in the abdomen. I specifically, I'd like to do a lot of chest work as well, lung and esophagus, esophageal cancer and lung cancer. But probably the far more majority is abdomen.
And if you'd say your bread and butter, the most common surgical thing that you do, what would that be, Mike?
Oh, do a lot of gallbladder surgery, hernias, colon, esophagus, stomach.
Just the whole broad picture.
Yep.
And Cristina, you take care of people who have GI problems. I mean, what would be the majority of the, what was the biggest problem that you take care of the most? I mean, what's your...
Well, I've kind of even subspecialized within my specialty. So I see quite a few inflammatory bowel disease patients, so patients with Crohn's disease and ulcerative colitis. But my most common complaint in my GI clinic is bloating. So, I mean, we see all sorts of causes for bloating. But yeah, a typical day I can do EGDs and colonoscopies.
What's an EGD?
An upper endoscopy, a flexible tube which is inserted through the mouth and looks inside the esophagus, stomach, and the first portion of the small bowel. Typically people have heartburn symptoms or abdominal pain that we're trying to figure out.
So it brings to mind, my sense is that there are a lot of people who should be having EGDs that are not. That's a leading question, though. I mean, who are these people? What is an indication for a esophagogastroduodenoscopy, the EGD, the look down the esophagus and into the stomach?
Well, I think the guidelines are somewhat changing and shifting. We would typically think of the patient who's had heartburn for many years, at least 5 years, or a person who's over the age of 50 who's had heartburn that really hasn't been well controlled on a medication that is supposed to reduce acid. But some of the latest thoughts and findings for people who have precancerous conditions of the esophagus, you find those conditions actually more commonly in people who have chronic cough or throat clearing, and really kind of a new entity called laryngopharyngeal reflux, or LPR. So really the EGD is becoming a really valuable tool, and we have to think of using it more frequently than what we are right now.
And that strikes me as and of course I realize this because there are a lot of people who have vocal cord dysfunction, and so automatically my ears, nose, and throat doctor, Dr. Reitz, starts these people on omeprazole. Is that what you are doing with those?
Oh, typically we are, and it's somewhat of a controversial area. If you take 100 people off the street and look at their vocal cords, they are perhaps a little bit swollen and red. Can we attribute all of that to reflux? The simple answer is we don't know yet, but it does not hurt at this point in time to try a medication like omeprazole to reduce acid.
Prilosec or omeprazole.
Absolutely.
Any comment that you would jump in on that one, Mike?
Well, and she's talking a lot about the medical treatment for reflux, and you know, from the surgical perspective, once the medical therapy has been exhausted, there are some people who maybe benefit from what we call Nissen fundoplication, or what many people call a stomach wrap.
A stomach wrap, so they wrap muscle around the bottom of the esophagus to kind of keep it from coming back up the esophagus?
Exactly. Sometimes people develop a opening at the end of the esophagus, or the sphincter that's partially there kind of relaxes, which can cause people to develop reflux symptoms. And typically medical therapy works for the majority of people. But there's sometimes where there's indications where if people are on high doses of medical therapy and it's still not giving them their symptom relief, sometimes surgical intervention can be beneficial for them.
And I sense that if we have a person with a lot of bad reflux, it really sets them up for cancer. That's the nervous thing about it. And we can talk about Barrett's esophagus and those things in a minute, but we have a question from Aberdeen. 3 months ago, had 4-level fusion on the neck. Felt good for 3 months. About 2 months ago, started awaking with white foam in the night. Has been treating it as acid reflux, but it's gotten worse. Can anything be done? So do you see any association with the problem of the neck surgery and association with reflux first, and then what can be done for this gentleman?
Well, possibly during the neck surgery, doing that exposure for that surgery, there are several nerve structures that are in the vicinity of where that exposure is. And it depends. There's different exposures for the neck, but occasionally some of the nerves can be partially damaged or stretched, and that can cause a temporary dysfunction of some of your swallowing mechanisms in the back of your throat and your pharynx. And that can definitely, put you at risk for aspiration or not so much reflux, but
the food, not the swallowing mechanism is not working so well.
So like a swallow study, would you think that might be a next step?
That might be beneficial. Where you just actively have someone swallow during the x-ray, and you can actually watch the contrast go down and see if anything aspirates into the lung.
Chris, what would you say? Any comment or anything to add?
No, I agree completely, and I don't know if it's really reflux that would be causing all of that foam. And if it is reflux, majority of people are going to respond to medication for reflux. So that's a pretty good test in itself.
So if it didn't respond to
I think you could, maybe try to increase to twice-a-day dosing, and then if it doesn't respond, I think you need to go searching for a different answer.
Yeah, more testing. Yeah. Well, you're living your life. You eat well, are in good shape, you feel great, and then you eat dinner, and all of a sudden there's this sharp pain in your abdomen, and you know something isn't quite right.
About a month ago, I ate a meal and felt really sick immediately. I got a real full feeling in the upper right part of my abdomen, and as time went on, I thought, oh, it'll go away. About a week later, I started to realize I was having some sharp pains in my side and right under my shoulder blade in the back. As I told Dr. Holm when I saw him the first time, I said, I feel great except for this. I mean, everything else is great. I mean, my blood pressure is good, my weight is good, and I was, I exercise a lot. I felt great. At first they did an ultrasound and just found some slight issues with the common bile duct, and because that was unclear, we did what's called a HIDA scan, which is they inject you with a radioactive isotope and then put you under a detector and watch where the blood goes, and eventually everything goes to your liver and then to your gallbladder, and then they measure some sort of rate that it gets rid of this thing. Okay, so my doctor, Dr. Holm, told me that anything under 35 would be considered bad, and mine was 16. So basically I had a non-functional gallbladder at that point. It just wasn't working. 2 days later, I had an appointment with a surgeon, and the day after that, I had laparoscopic surgery. They did both a cholecystectomy, which is the gallbladder removal, and a cholangiogram, which is injecting some dye so they can see if the common bile duct is working right. The process of laparoscopic surgery, while it's much less traumatic than open surgery, there are still some pretty serious consequences. I mean, it is abdominal surgery, and in fact they sort of blow up your abdomen with, I think, nitrogen is the gas they use, and they can't get it all out, and what you really suffer are pains from the pockets of gas that remain inside your abdomen. You get pain in your shoulder, and I had some pretty good pain in my shoulder. I had real severe pain right where the gallbladder used to be, and I called up Dr. Holm again, and he said I needed to go in and make sure it wasn't a blood clot or something serious. They did some x-rays, and it was a big air bubble sitting between my liver and my diaphragm that was sort of squishing everything, and you can imagine when you breathe, it hurts. I taught a class 5 days after the surgery, but I was worn out after I got done. So once the sort of air bubble problem, those things went away, it was just being tired for quite some time. Immediately when I started getting sick, I basically stopped eating. And that's a common thing that people do when they start having gallbladder problems. They just stop eating because it's painful when you eat. What I had been eating was low fat, which is always a good idea, but essentially now I'm eating almost no fat and trying to stay with some sort of basic things. I haven't, they say start reintroducing foods slowly so your body can kind of adjust. One of the things that you realize when you're forced to eat differently is that it truly changes the way you feel. Eating a lot of heavy, fatty foods really, you realize, makes you feel kind of rotten. And so part of feeling really good right now is that I'm eating good stuff. Sure, do I miss going to George's Pizza and having some of their awesome pizza? Yeah, but that's just the deal now. The thing about the gallbladder that's so weird, it's one of those things that if it doesn't work, you're sick, but when it's gone, you can be just fine. I mean, it just seems odd to me that there's an internal organ that, you know, it's functional and vestigial at the same time. Do you need it or not?
Functional or vestigial, you know, is it important or not? I mean, gallbladder is a mysterious organ. I remember reading from the surgical textbook that I grew up on, and they said, here are the classic symptoms of gallbladder. You know, it's fatty meal, and you have bloating, and you have flatus, and which is a gassy rectal, you know, how do I put that? And you have this classic right upper quadrant pain that hurts when you eat the fatty meal, and so on and so forth. Except to tell you the truth, that most people who have gallbladder disease have no classic symptoms, that it just does weird things. What's your comment about gallbladder disease and how it presents?
Well, no one's ever, you know, always a textbook. I mean, sure, we see quite a few that people, you follow the kind of the standard symptoms you expect to see, but a lot of times it can be a little bit tricky. It was a little bit different. Many times people come in, they think they're dying of a heart attack. They've gone through multiple workups of their heart, trying to figure out what's causing this chest pain, and you know, ends up being their gallbladder. And some people don't have any of those types of pain. Some people just have bloating. Some people diarrhea, just pain in their back. It's just very variable.
Pain on the right shoulder, sometimes when it's up on the, irritating the area up under the diaphragm. Chris, what's your comment about the gallbladder and symptoms that people could have?
No, I agree with Mike completely, and oftentimes it's sometimes the most obvious, but yet it's the last thing you think about, and because of you get somewhat swayed by, oh, it's my chest, or is it spasm that I'm having, or, you know, am I just feeling uncomfortable with, you know, other things? So, yeah, you can be somewhat sidetracked, and then you, of course, think, well, what about this gallbladder? It's not the typical pain starting in the middle, going to the right side, but sure, we'll check you for this, and easy testing, and send it to Mike. So
here we have a case of a gentleman with a dysfunctional gallbladder. It wasn't the classic ultrasound that goes, there's the problem, take me out. It says, it might be the gallbladder, and then you do a functional test and it doesn't work well. And so how often is that something that when you remove the gallbladder it solves the problem? Mike?
Well, if you
tough
look
question, I know. I mean,
you know, and if you look at the literature and you go by, you know, look in the ejection fraction being less than 35%, and also what we look at is also sometimes during that test, some of the medications you're given during that test can cause similar symptoms. And a lot of times if you see that reproduction of symptoms or that abnormal ejection fraction, what we know is about 85% of those people usually get better. And why the other 25% or 15%, sometimes it may not be the right diagnosis. Yeah. Maybe something's going on. So I think even though you may have this study that says this, there's plenty of people out there who have low ejection fraction of their gallbladder, but their gallbladder is not causing the problems. Yeah. So you have to kind of be a little bit skeptical.
Yeah.
And when I'm faced with kind of one of those situations, I'll say, I'm going to send you to a surgeon who's going to sit down and talk to you, because, you know, I don't have a good feeling whether or not this is going to entirely get rid of your symptoms. And then, you know, the surgeons really go through it very nicely and explain it, and most people want it out. They're at that point willing, saying, take it out.
They're not comfortable, and actually the surgery is not nearly as painful post-operatively as it used to be. I mean, it used to be they would be in the hospital 2 weeks for recovery. I mean, that way before your day, and your day too. So I just remember one gal. Remember when Tagamet was the only? You probably don't remember that either. But Tagamet was the first drug that we had that turned off the acid. And prior to that, we had surgical treatment for all peptic ulcers. I mean, we went in and we cut out the ulcer. That's it. When it got bad enough and it bled. Okay? So she had Tagamet, and she came in and she says, I need the Tagamet again. I'm really sick. And the Tagamet didn't seem to do it. And I did the ultrasound, and there was a sick gallbladder, removed it, and she said, I've been treating this with Tagamet all along, and it was the wrong diagnosis. And I just think about that case, and I think that abdominal pain is an elusive, tough, hard to diagnose type of a thing sometimes. We think we know what it is, and it isn't always the case.
Yeah, we see that a lot. I mean, sometimes cardiac disease, reflux, and gallbladder problems all present very, very similar. And
is it a heart attack? Is it heartburn, or a reflex esophagitis, or could it be gallbladder disease? Difficult call, isn't it? Yeah. We have another question from Ipswich. How would you treat nutcracker esophagus? What is that? Cristina.
Hyperperistalsis of the esophagus. Your esophagus squeezes much too hard, more so than what it should. So
it's trying to crack the nut. It's really,
exactly.
Really
the esophagus just isn't this tube that food goes shooting down. It's coordinated. It squeezes in a very nice manner called peristalsis. And when you eat, sometimes that esophagus just doesn't work the way it should, and so it will squeeze much too hard. And typically medications we use are medicines that relax the esophagus, such as nitrates, good old-fashioned nitroglycerin.
For your heart, but it helps the esophagus?
Yep, exactly. And calcium channel blockers like verapamil or diltiazem.
Okay. Any extra?
No, I agree. It's typically not something that's, surgery is really not recommended for that.
A non-surgical disease. And you treat it with a little nitroglycerin. How about that?
A little bit of medication, yep.
Gastric paralysis. I've run into this a number of times. This is a real problem for some people. The stomach doesn't want to empty. A large percentage of these are diabetic, right?
Yes and no. We typically think of diabetics as the most common cause, but it's actually a 32-year-old white woman is the most typical patient who has
diabetes.
Without diabetes, and we theorize it's due to some type of viral infection that affects autonomic neuropathy, and so these individuals will struggle with bloating, pain. I mean, we could think it's the gallbladder even, and in the end, their stomach is just not wanting to empty out. Gastroparesis, paralysis of the stomach.
And so how do they grow out of it? Is this a lifelong problem? What do you do to get them to work again?
Well, you can put them on a gastroparetic diet, low fat, low fiber, small frequent meals. Liquids are better than solids, is what I tell my patients. And there are medications that can help the stomach to empty out. Reglan, although because of the side effects we're trying to shy away from that a little bit more, but even using erythromycin, which is an antibiotic, but we use it for the side effect of increased gut motility.
I mean, everybody's always complained that their gut hurts when they take erythromycin for antibiotics.
And so now we're using that exactly for the benefit. And in rare cases, then there would be an experimental surgical approach too with a gastric pacemaker.
And how has that been working for you?
Well, it's not done in a lot of places in the United States. We actually did some, when I was a resident, we did quite a few actually, where I trained.
And it's sort of like a pacemaker.
It is.
Do you run the stimulant along the stomach, or what? How does that?
Exactly. It's basically the batteries inserted into the abdominal wall, and the cable is run right to the cardia of the stomach, or the main body of the stomach.
Right.
And acts just like a pacemaker for the heart. It sends electrical stimulations, and you can adjust those stimulations to try to make the stomach peristalsis more. And we have seen some success with it, but by any means, it's not the miracle cure for gastroparesis, and it's a bad problem, and people are pretty miserable.
Tough problems. I've seen people waste away to almost nothing.
Feeding tubes, hospitalizations.
Severe malnutrition.
It's a tough problem.
It is a tough problem.
This caller from Scotland believes her granddaughter has Hirschsprung's disease and doesn't have nerves to get the things running through, she says, is always on Miralax. Would surgery be a good idea? How would bowels be controlled? How do you handle? Okay, so what is Hirschsprung's disease, Christy?
Well, aganglionosis of the very bottom part of the colon.
So it's similar to this gastroparesis, but it's the lack of the stimulation in the rectal and the bottom part from the sigmoid on.
Right, and we see it primarily in children. So this isn't a disease I see as an adult gastroenterologist, but you can diagnose it in an adult rarely by doing a study called an anal rectal manometry, checking for strength of contractions. But I think the full thickness biopsies.
Yeah, that's really the diagnosis of choice is take a biopsy of that tissue in the rectum.
And most of these kiddies.
Yeah, it's not an acquired disease like gastroparesis typically is. This is something you're typically born with.
All right. And the treatment is?
Usually it's surgical. It depends. There's different severities of how this is. I mean, some adults are not, or some people aren't diagnosed until they're adults, just because they have very mild disease. Usually the severe ones are typically treated surgically.
And that means that instead of going to the rectum, you bring part of the bowel to the abdomen, you have a colostomy.
That's one, but there's typically, we try to take out that bad section of the bowel and actually create a new rectum and attach that back. Try to create a new system to where they can still go to the bathroom normally.
Yeah. Let me ask this. This is a question that I've had a ton lately. Just had one in today. I've got these old internal and external hemorrhoidal tags. Now we're talking anus. Anus is a very sensitive part for everybody. Of course, it's hidden. Nobody admits to having an anus. I mean, it's the. But we all need them, or most of us have them. So the question is, what about hemorrhoids? What about hemorrhoid surgery? And I said to my patient, I've not been impressed that hemorrhoidal surgeries help many people, and sometimes it hurts them by causing scarring, and then what you have normally is this floppy kind of this puffy, floppy tissue that kind of fills in and keeps you from leaking. And if you mess with it, you end up with scar tissue, and then it leaks. Okay, so surgeon who probably has done hemorrhoidectomies, defend yourself.
Well, there's different types of surgery, I guess, for hemorrhoids. There's sometimes for the internal hemorrhoids, which are the ones more on the inside of the rectum, of the anus, is sometimes you can do banding. Basically what you do is you put bands around these hemorrhoids, and eventually the blood supply leaves those hemorrhoids, and that tissue just kind of falls off. However, some of the more severe ones, requires an actual excision of those hemorrhoids, and those can be quite painful.
Yeah.
And people are pretty miserable.
They talk about poop and broken pop bottles.
Yes.
What I keep hearing about.
Yeah.
So, but most of the time, you kind of leave the rectum alone if you can.
Yeah, typically, and we try to do diet modification, stool softeners, and some topical pain agents, and that helps the majority of people.
Yeah.
It's not typically, surgery is not a first option for most hemorrhoidal disease.
And I think ground flaxseed is the anus's friend. Have you ever heard that?
Well, no, not in those terms.
Okay, well,
I must not get out very much.
You must not get out very much. That's the problem, because it greases up the colonic material, and it allows it to slip out a little easier.
Yeah,
Too much fiber. Too much fiber. The old type of fiber, it's sticky, but when you've got the ground flaxseed, it's kind of slippery. So there you go. We'll talk about that in a bit. Usually when we have pain in our bodies, we look for the problem at the site of the pain or the discomfort. However, there are times with abdominal disorders when the symptoms are in one place and the cause in another.
Darnall is a 59-year-old business owner. He runs a greenhouse in Brookings, South Dakota. And his experience with peripheral neuropathy started when he began to lose feeling in the toes of his left foot.
I chose to ignore that and thought, well, that's something that'll pass. The right foot then did the same thing a month or two later, and started to get a little concerned, and then my hand did it, my left hand.
The cause of Darnall's nerve pain was diagnosed fairly quickly. Tests verified his doctor's suspicions.
He did some blood tests, and I was vitamin deficient, several areas, vitamin D especially, and some other things. And obviously I eat enough, so I I was getting the calories, but I wasn't getting the nutrients.
Darnall was diagnosed with celiac disease, an intolerance to gluten. Gluten, which is found in wheat, rye, barley, and oat food products, provokes an immune response in people with celiac disease, and it can cause intestinal damage and problems due to nutritional deficiencies.
Here's the newest thing that I found. Cheese-based crust pizza.
For Darnall, a gluten-free diet became mandatory.
Crust is actually
His overall health has improved, and his neuropathy is now waning.
Multivitamins, and the numbers, of course, are improving on my as far as my nutrition and everything, and I'm losing some weight, and that is taking care of the neuropathy. It's going away.
We can talk celiac disease after this. That's what we need to do. Let's talk about celiac disease.
Sure. Well, it's common, and I think people are really starting to realize how common it is. I tell people in this country, 1 out of 126 Caucasians is the number we're telling people who have celiac.
1 out of 126?
Yes. If you go to Ireland, which has the most prevalence, 1 out of 100 individuals. So.
What about in Asians, American Indians, Africans?
Well, it's
not so much.
Not as much, and so we don't know if it's genetic. It is something due to what we're eating. Is it a body's response to perhaps modified? We don't know. I mean, there definitely is. Well, it's an autoimmune and allergic reaction to wheat, barley, and rye, the protein in those grains. And so the small bowel will become damaged, and a person is unable to absorb nutrients.
So it's this kind of weird allergic thing. It comes on upon them as they're an adult.
Not always. Sometimes in children, and that's really kind of the classic celiac patient is a young child who's severely malnourished, who's not growing, is going down on the growth chart. So that's kind of the classic patient. But we're now finding the more typical patient is someone we're doing an EGD and we're driving through the small bowel and, hey, this looks kind of funny. It doesn't look like the normal villi should, and so we take a biopsy and then we'll discover celiac disease. But now there's a great blood test, so that's even more of a simple way to diagnose celiac disease.
This gentleman had peripheral neuropathy, which I presume is B12 deficiency that was doing it.
Absolutely.
And I didn't have any other clue except that he said, and gee, my sister came down with this. Could it be that? Duh.
Yeah.
So as a brilliant clinician, I made the diagnosis. But another patient that I had presented with weight loss and iron deficiency. And so he's anemic. I'm going, I know this is colon cancer until proven otherwise. We've got to do the colonoscopy. So I did the colonoscopy. There was no colon cancer. It was just a normal colonoscopy. Got an EGD. So we went down there and the guy said, gee, the villi and the duodenum looks a little funny. Took biopsies, consistent with celiac disease, put him on a celiac diet, gained all this weight back, his iron deficiency went away. And
people feel wonderful. I've had women who've had miscarriages, the celiac. It just is such a common thing. Epilepsy, it's all related to celiac.
And
we don't
rashes.
know why. Yeah,
weird rashes.
Absolutely. Dermatitis herpetiformis, a horrible rash that can be completely controlled with a gluten-free diet.
Describe the rash a little bit.
It's on the elbows and shins, and it's raised, and it's extremely itchy. And once you itch it, it will blister over and bleed.
All right, and I think that if there's any family history, you should have it tested. I remember looking at one article in the Annals of Internal Medicine that talked about all these family members of celiac disease who didn't have symptoms, right? So we tested them. They had the blood tests that were abnormal, so they put half of them on the celiac diet, and the other half, because it's a pretty rigorous diet.
Yes, it is.
And the other half, they left them alone, and they followed them for a year, and the people who were put on a celiac diet, who had felt normal, felt much better, and it was well worth it for them.
Absolutely, and it's important to be very strict about the diet. You want to decrease your risk of small bowel lymphoma. I mean, there's a lot of serious,
that runs with it.
Serious consequences. So so if you are diagnosed, make the commitment, and you're going to feel great.
Mike, we left you out. Any comment about celiac disease?
You got it covered just fine.
All right, okay. Here is from here, and how long can a person be on omeprazole without side effects? What are the side effects or is it better to do it with surgery? I mean, what are the side effects of these drugs, you know, Prevacid or omeprazole or even Zantac, the H2 blockers? Long-term side effects?
Well, long-term side effects, we tell patients osteoporosis, osteopenia are high on the list, as well as now increased risk of a Clostridium difficile infection in hospitalized patients.
That's just diarrhea, overgrowth infection.
Oh, that's horrible, yeah. It's just a horrible infection. Short-term side effects of these medications, headache, nausea, diarrhea. But the long-term side effects, definitely a person needs to consider, you know, if you're at risk for osteoporosis, there might be better options, or you could use that medication more intermittently than regularly. Or even think about switching back to the old medicine like the Tagamet or Zantac.
And what about the withdrawal? I mean, I've heard that if you stop omeprazole, even if you'd never needed it and the study put them on it, and you stop it abruptly, people will have withdrawal acid.
Yeah, they can. They can have this hypersecretory state, and so, you know, when I'm telling patients to go off of that, that's the time to try to use a little bit of ranitidine, and not to stop it suddenly. Do every other day for a week or so, and even use the occasional Tums to help with that.
All right. So what about colonoscopy? This patient had, a Sioux Falls patient, colonoscopy, stomach peaked at as well, and then following that had swelling filling for 3 days and a feeling of a metal band around the stomach, and lost 12 pounds and can't eat more than a cup at a time. And could this have been related to the studies, or what do you think? Mike?
I don't know. That it could be more. It could be just retained gas and things from the colonoscopy. You know, and sometimes you do these preps and things sometimes for these colonoscopies and upper endoscopies, and sometimes that can kind of throw off your bowel function a little bit for a while. Yeah. But yeah, that'd be my best guess. I don't know what you think.
Oh, yeah, it's common for people to say, I just didn't feel right for 5 days, or I didn't go to the bathroom again. What's going on? Well, your bowel's been completely cleaned out. It's going to take a little while, but I agree with Mike that the air inside, perhaps they had to maneuver the patient and press on the patient to help the scope go around a corner or such.
If there's an acute problem, that's, you know, you can perforate the bowel. I don't care how good you are. The studies say 2 or 3 per 1,000. And you can, even if you don't pluck a polyp, you can perforate the bowel. So those are risks. But generally, they'll tell you if there's a perforation. You know, they'll come in with big-time symptoms. I presume that this could have been a perf, but was just a minor one that healed itself, and then the consequences took a while to heal.
Sure.
Yeah, it's definitely possible.
Sioux Falls, what is the latest medical news for treating and curing Crohn's disease and ulcerative colitis?
No cure yet, but great medications. I think we're getting closer and closer. And so the latest and greatest are for moderate and severe Crohn's and colitis, are very targeted medications that look at a specific and treat a specific part of the immune system. But these are the expensive medicines. These are $20,000, $30,000 a year medications that once you start, you really make a huge commitment to be on them lifetime. Because if you stop, you're never going to get the same response. You could have antibodies, or you could have even an allergic reaction to that medication again. So even though there are great new medications out there, you really need to talk with your gastroenterologist or practitioner about, am I ready for this commitment? Is my disease that severe?
$20,000 to $30,000 a year. Even if you don't use the biologics that are expensive like this, the drugs that we're using for them are still very expensive.
Oh, you know, $300, $400 a month, and you know, everyone's insurance is goofy now, and so you know, it'll pay some or it won't pay some of that. So yes, there's still a good old-fashioned one called sulfasalazine, which in some of my ulcerative colitis patients is the best treatment, and that's been around 30, 40 years.
And it's dirt cheap. Well, it's pretty cheap.
Yeah, $4 a month.
Yeah, so I go with that one, and when they're not doing well, I send them to you and let you give them the bad news.
Yep.
Any comment about that?
No, it's tough. Financially, it can be really devastating to somebody. I mean, especially some of these people who don't have insurance, it can be a big problem.
And I guess the cure for UC is surgery. Thinking of it that way, removing the colon.
Ulcerative colitis.
Yeah.
So, I mean, let's say that you have ulcerative colitis, and they used to say that it isn't a matter of if you'll get colon cancer in a person with ulcerative colitis. It's a matter of when, because people with ulcerative colitis, not Crohn's, but ulcerative colitis, truly get higher risk of colon cancer. What's your take on that?
Yeah, that's right. Usually we start seeing it at about 10 years is typically the time from the onset of ulcerative colitis to time of cancer. That's a pretty common time that we'll start seeing that happen. It could be sooner, it could be later, but So we know that risk, and we know the treatment of this is limited somewhat. Surgery is a good option for ulcerative colitis.
And so when you do this, people have talked about not saving the rectum because the rectum can also get the cancer. So what you do is the colostomy, right? Or is that
colostomy? Well, and you can. It really depends on your preference a little bit. And it's different for every patient. Typically, the younger patients would like to be hooked back up. And the risk of that is you still have some of that remaining colon and rectum there. What that means is you're going to have ongoing surveillance for the rest of your life. And it really depends on whether that's something that the patient wants to go through. There's usually like a 3-stage or 2-stage procedure that you use to go through that operation. It's 3 operations. But that's, from my experience, most younger people
like to have
that. Yeah.
And they do this certain kind of pouch. What do they call that?
A J-pouch.
J-pouch.
Yeah. So it's not like a normal rectum, but you've made them a new rectum.
Yeah, and you're never going to be normal with this. You're going to be having multiple bowel movements throughout the day. There's complications with it. You can get infections in the pouch. So by all means, you really can't go back to a normal way of life, but at least a moderated type of view.
I tell my patients you're going to be trading one disease for another. And just like what Mike says, and you're never going to have that one bowel movement again. It's going to be 6 to 8 to 10 every day, and sometimes in the middle of the night.
And sometimes a colostomy is not such a bad deal.
Exactly.
People always, I don't want to have a colostomy. There are a million people out there walking around with colostomies, and you don't know. It's not a bad deal.
Yep.
I have to tell you the good news. I had one patient I did a colonoscopy, and there in the proximal colon, right up to near the cecum on the far right, was this broad, benign-looking but large polyp, flat polyp. Okay, so it's broad. So I took a biopsy, and then I cauterized it very lightly and hoped that I didn't perforate the bowel, and got out of there and repeated the scope a year later, and it's bigger. So I said, it's a benign biopsy both times, but it needs to be removed. And so the guy had it removed, and I saw him today, and he said, "Say, I have to tell you that since you had that surgeon remove that part of my bowel, my constipation problem's been resolved. I just have the best normal. I'm just as good as could be, and thanks a lot." How about that? So we have a question over the last several years has been experiencing coughing, clearing voice, loss of singing voice, has seen the internist, pulmonologist, EMT, did laryngoscopy. Nothing shows up on tests. Condition attributed to reflux has shown no symptoms of reflux. Would EGD be the next step?
I would say yes, and then I would also do what's called a pH and impedance study, a special type of study that will look at reflux of acid and non-acid contents over a 24-hour time period. It's great. Patients eat, they go to work with it. It is a little tube outside the nose. And every time that patient feels like he or she is coughing, they'll hit a button. And I can get all this information and I can say, yes, every time you're having this coughing episode, there is reflux of acid. Or I will say, nope, there's no acid here. In fact, your acid never even comes up to the uppermost part of your esophagus, so we can't blame acid with this.
I have a patient who has tremendous esophageal swallowing problems, and the tests have all been normal. We've looked at the vocal cords, we've looked at the epiglottis, we've done the barium swallows, we've done the swallow studies, we've done EGD and the gastroscopy, and everything is normal. So we sense that it's a panicky fear thing. A younger woman. Do you see this often, and what do you do for it? Either one of you.
Occasionally, and really in this situation, it's really a diet modification. Finding things that are easier for them to swallow, working with them about, maybe taking smaller meals, taking your time eating, really chewing your things up. And sometimes just that alone can give me a sense of
getting something
done. And then there's just some foods that are hard to swallow. For anybody sometimes.
Some people tell me the guy who had eosinophilic esophagitis said, "I was fine. I don't have a lot of problem except I can't swallow chicken. Dry white chicken." Is that a clue to anything other than the fact that this guy had an eosinophilic esophagitis?
Well, I think dysphagia or trouble swallowing, if it's with food items and it's getting progressively worse, yeah, that's a big warning sign to get that EGD done. Let's look inside your esophagus and make sure there's not a cancer there that's obstructing the esophagus. With eosinophilic esophagitis, there can be a multitude of reasons and allergic, food items. I've had a patient who can't eat raw tuna. She can't go eat sushi because she's so uncomfortable and she has this swelling of her esophagus. We've worked with allergists who've determined tomatoes, corn, cantaloupe. I mean, it's all over the place. So, but I think any progressive dysphagia, worsening with swallowing, you need to see someone quickly.
No, sure. So I think that's the real important take-home message that you guys need to remember. If you're having trouble swallowing solids, liquids go down, solids, if you're having trouble swallowing, you need to have it scoped. You need to get in and get it taken care of. I have a call for you, Cristina, on a couple of prescriptions. Lialda, azathioprine, what are the long-term side effects? Lialda.
Lialda is a mesalamine product for the treatment of ulcerative colitis. It is wonderful in that you only have to take it once a day to get the full benefit from it, unlike its older counterparts. Long-term side effects, we worry about renal, kidney disease. Azathioprine is a medication that kind of turns down the volume of the immune system so that the body will not attack the colon. Now that has numerous long-term side effects, and we follow liver very closely, the pancreas during the first year, as well as white blood cell counts. The most feared complication, though, is lymphoma, and it happens. So you need again to have that discussion with your practitioner. But what I tell my patients is that more people die from prednisone every year than they do from the use of azathioprine, and we sometimes
it's an alternative.
Yeah, and sometimes we kind of throw prednisone around like candy. And so I think these are good medications for the moderate to severe Crohn's and colitis.
Okay. Diagnosed with B12 deficiency, could I have celiac disease?
Sure. Yeah. Or Crohn's.
Or Crohn's.
Mm-hmm.
Hot Springs, please tell me about gallbladder pacemaker and what it's called, what causes stomach peristalsis. So it's not a gallbladder pacemaker.
Gastric.
It's a gastric.
Pacemaker.
And so we've discussed that. How about in Elkton, acid reflux, Nissen wrap, it slipped. What should he do to get it? Should it be redone? What about the gastric, the Nissen wrap? Again, you wrap muscle taken from where?
So basically you're actually wrapping the stomach on itself, and you're actually kind of wrapping around that stomach right where the esophagus comes into the stomach itself. And you can kind of mobilize the stomach and just basically make a horseshoe around it, and it helps squeeze and keep those food and fluids from going up in your esophagus.
And can you redo it?
You can, and slippage can happen. It's reported anywhere around the 8 to 10% range, and typically it requires revision.
Okay. And are there other new treatments besides the wrap that are effective, easier than for esophageal reflux surgical treatment?
There's some endoscopic methods now. That's what we've talked about, going down with your esophagus with a scope. And basically sometimes there's procedures where you actually sew the bottom of the esophagus using some of the tissue and closing it up and making it tighter there as well. Okay. And that's kind of a newer treatment, and kind of the jury's still out on how that's going to work out.
All right. Well, Connie Constipation is an older woman who has controlled almost everything throughout her life except for her bowels. It seems the harder she's tried to make the bowels move, the more constipated or irregular she's become. She's always sought for the right laxative and is now using herbal lightning without a lot of success. She commonly feels bloated, waiting for the call, often sitting on the commode for long periods of time, pushing too hard, and then she's loose as a goose, having tripled her laxative dose. Connie is one frustrated woman. The causes for constipation are numerous, to include too little exercise, too few fiber foods, internal scars from previous surgery, diverticulosis, low thyroid, even colon cancer. Certainly, everyone with constipation needs to consider first seeing a doctor for the proper evaluation. But I believe the most common cause for constipation around here is the long-term use of the stimulant type of laxatives such as X-Lax, Correctol, stool softener with laxative, Senna, and many herbal type combinations. Realize that abruptly stopping stimulant laxatives cause rebound constipation and thus dependency. Many people have a problem perpetuated by the very drug they used to treat it. This is the reason to gradually taper off these bowel irritants and then avoid them in the future. Good bowel health starts with exercise, a diet of fruit, vegetables, fiber foods, and then, if needed, by adding ground golden flaxseed. I suggest buying it whole, grinding the flax in a coffee grinder about half a cup at a time, prevents it from turning rancid, and then daily mixing 1 or 2 tablespoons with breakfast cereal or yogurt or applesauce. If an individual is still having problems, I advise plain stool stool softeners without laxative. Start with 1 to 3 capsules once or twice a day, adjusting the dose accordingly. If necessary, rescue with over-the-counter polyethylene glycol, also called Miralax, milk of magnesia, or sorbitol. These are effective and don't cause rebound. If she exercises daily, eats the right food with enough fiber, and avoids laxatives, then Connie will be back in control. Any comments about my suggestion of... You have a question.
Well, no, I'm nodding in agreement. I think if we all did what we should, which is eat well, eat enough, not too much, and exercise, a lot of our GI and abdominal complaints, would just go away.
Mm-hmm. Yeah. I noticed that when these people who've had bowel problems their whole life long come into the nursing home finally because they're old from some, or they're having problems from some other thing, you stop the laxatives that they've been eating all their life. And they use a stool softener and a little Miralax, in about 2 weeks, the problem goes away. Do you deal with a lot of constipation?
Oh, we do. We see a fair amount of it. I was kind of wondering where you get this herbal lightning at.
Yeah. I kind of made that up. So,
they're a smooth move, right?
Let's talk about, take reaction to that comment. Any other things that you would like to add? We've got a few more other questions, and I don't know that I'm hearing my feedback here. What's going on here? So we have some time to talk about important take-home messages.
Well, I think probably the most important thing is everybody develops abdominal pain at some point in their life, and it's always a problem of deciding what's serious and what's not. And I think what you have to be careful of, if the pain is ongoing, it's not really getting better within a couple hours or several hours, and it's the most severe pain you've had, then get medical attention. Because sometimes what we see, people sit on these pain for several hours, and they get a very serious problem. And sometimes it's too late by the time they come in. They wait too long.
So not waiting long. Not waiting, but coming in and getting help when you need it.
Yeah.
Cristina?
I think the same line, and we didn't really go into colonoscopies, but not being afraid of those procedures and not being afraid of going to the doctor, even if it is just a little bit of rectal bleeding, and it just probably is my hemorrhoid, and just not being afraid to interact with your physician and bring up this issue, even though it might be uncomfortable. These things could save your life.
What do you think about the screening colonoscopy at 50? Do you think it should be done sooner?
There's been numerous studies looking at that, or decreasing time intervals, and 50 is still kind of the magic age because most colon cancers will take 10 years to develop, and we see the incidence bump around age 60. For African American men, though, our societies do recommend starting at age 45.
Yeah, family history, I think, is big too.
Exactly.
Your father had colon cancer, mother had colon cancer, brother, then definitely on the earlier side than later.
I'm definitely one of those. My dad had colon cancer. I'm kind of sensitive about the whole thing, and I've had polyps on my repeated colonoscopies, so I'm on a watch. We've got a couple more questions. I think we have time to do that. What, do we? We have time? No, we don't have time. So they're running through this thing. I'm going to ask you about reflux umbilical hernia repair quickly.
Okay.
What about hernias and hernia repair?
Well, umbilical hernias are one of the most common hernias that we see. Very common in kids, little kids, and that's probably one of the most concerns when you have a little baby, you see this hernia forming. A lot of parents are concerned about that. Most of the time these hernias go away, and you usually wait till after age 2 before we think about repair of those. But in adults, hernias can be dangerous, and you're at risk of having bowel trapped in that hernia, losing blood supply and dying, and that can lead to severe complications. So if you have a hernia, get it evaluated by your doctor.
And I generally say as long as it's not hurting a lot, you're okay. And there's some people who are at higher risk.
You know, yeah, you're correct. Not every hernia needs to be fixed, and but there's certain types of hernias and sizes that are more dangerous than others, and those are the ones we try to focus on.
All right. One of the many friends of On Call is Dr. Annette Bosworth, who's active and positive force for improvement of healthcare outcomes here in South Dakota. She organizes trips to Haiti for medical students that give them experiences as doctors that couldn't get elsewhere. She works to combat childhood obesity and to find successful methods to treat those with addictive behavior, these kind of things that aren't paying very well. I would encourage you to visit her website, AnnetteBosworth.com, and see for yourself what she's doing here in South Dakota and beyond. And now, thank you, our viewers, for watching and calling. Your questions and input do make a difference. Until next time, stay healthy out there, people, and thank you.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.